tell you to like get closer, but it picks it up.
Oh, I can hear you. Start. Okay. Good afternoon. Hi, thank you for joining us today. My name is Miss Shalene, and I'm proud to be a part of MD Anderson in several different ways. I am a part of the Volunteers My Cancer Connection Steering Committee. I am a breast cancer survivor, 4.5 years, 4 years, 5 months. So I'm getting ready to go to Survivors Clinic. I'm so excited. I'm gonna miss them here. And I am an employee of MD Anderson for 18 years. I'm getting close to retirement there too. I would now like to welcome you and our fellow participants at the MD Anderson Cancer Centers in the Bay Area, Katy, Sugar Land, and the Woodlands, as well as those watching remotely. At today's Partners in Knowledge, News, and Cancer program. Piknic is one of many programs of My Cancer Connection in the Department of Volunteer Services and Merchandising. This series is brought to you in an effort to enrich our survivorship programming, and is generously, we get to eat, have drinks, and everything, generously funded by the Volunteer Endowment for Patient Support and Gift Shop proceeds. My Cancer's Connections mission is to share hope, support, and understanding to all others challenged by cancer from those who have been there. More information about My Cancer Connection programs can be found on the program cards at each of your seats. Did everybody get one? Before we begin the program today, I would like to bring to your attention that this session is being recorded by UT Television and will later be available on My Cancer Connection website. You're special. You're special because we're going to be famous, we're going to be on TV, and you know that we only give you the best at MD Anderson, right? So, it is my pleasure to introduce to you today's expert. Dr. Nicholas Palaskis received his medical degree from the University of Texas Health Science Center in San Antonio. His postgraduate training included internal medicine residency at Baylor College of Medicine, followed by a clinical fellowship in general cardiovascular diseases at Baylor College of Medicine, where he received advanced imaging training. Dr. Palaskis is a level 3 echo-trained physician. And I tell you, the best, right? He has American Board Internal Medicine certifications in internal medicine and cardiovascular disease. His research interests include using new echocardiography, is that right, Dr. Palaskis? Techniques and modalities. Oh. For the early detection of cancer, therapeutic-related cardiac dysfunction. He is also involved in medical student, resident, and fellow education and training. Please join me in welcoming Dr. Nicholas Palaskis.
Thank you for that wonderful introduction, and thank you all for inviting me here to talk to you today. It's great seeing all of you, caregivers and patients and volunteers that have been through so much with your cancer treatment and survivorship, and then those caregivers who support your family members through that. So that's really excellent to see all of you. So a lot of people ask me when they say, why are you a cardiologist at a cancer hospital at MD Anderson? And well, you know, the two most common or the two of the biggest medical conditions that affect people in the U.S. are heart disease and cancer. And so what better place to be than MD Anderson, where I can treat people's heart disease and be part of the wonderful oncologists we have here that treat your cancer. So really, I couldn't think of a better place to be as a cardiologist, actually. So today I'm going to talk to you about how we monitor your heart while you're receiving different cancer therapeutics. You know, the reason I say cancer therapeutics now is because we used to call everything chemotherapy, but now with the new targeted therapies that these oncologists are developing, and they're using your own immune system to fight cancers, and so now we can no longer call all of these things chemotherapy. We more generally term them cancer therapeutics. And so I'll talk about how we monitor your heart to make sure your heart stays safe during these cancer therapeutics. And I want to highlight that most of what we do as cardiologists at MD Anderson is general cardiology, managing people's cardiac conditions that have no relation to their cancer and no relation to the cancer therapy they receive. A very small portion of what we do is actually managing toxicities from the cancer therapeutics that you have received or may receive in the future. And I want to highlight this because I don't want you to come out of this presentation scared that, all these cancer therapeutics cause a lot of cardiac conditions. In reality, this is a very small portion of what we manage here, and most of it is as we age, we develop some heart disease and have higher risk for cancer as we age, and we help manage these heart conditions along with your cancer treatment, and it's not from the cancer treatment itself. So basically, I'll talk about a little bit of a background and why this is becoming such a big field and why it's becoming so important to monitor the heart during cancer therapy. I'll talk a little bit about how we define cardiotoxicity, you know, what exactly are we looking at and how the heart's affected by different cancer therapies. And then I'll go through some of the most used cancer therapeutics that have known associations with heart problems, and then go through some of the newer cancer therapeutics that are being developed and how we're monitoring those to ensure that they don't have heart side effects. So right now there are over 200 approved cancer therapeutics in the market. And they're being developed by the wonderful oncologists here at MD Anderson. So 5 new cancer therapeutics were approved by the FDA in 2016 alone. I don't have the 2017 numbers yet. And cancer survivors are expected to increase from 15.5 million in 26 to over 20 million over the next decade. So these oncologists have done such a good job in finding ways to treat cancer and have people survive from their cancer that it's becoming more important that we treat your heart disease at the same time. And don't, a lot of the past cardiologists said, oh, this patient has heart disease, but they have cancer too. The morbidity from that cancer is so high. We should not get aggressive about treating the heart disease. Well, that's changing because they're getting so good at treating the cancer, and you're surviving from the cancers. We have to treat the heart disease too, and we can't let that go by the wayside. We have to be aggressive about that also. And so in 2013, the National Cancer Institute, or the NCI, they came together with a heart and lung group, or the NHLBI, and they wanted to address this exact thing about cancer therapeutics and the possible cardiotoxicity that are associated with them. And what they did is they brought together multiple cardiologists and oncologists to say, what's the knowledge gap? What are we missing about how these drugs are possibly affecting the heart? And one of the biggest things that came out of this meeting was defining a standard for how we define what heart disease is. And there's a lot of different effects that cancer therapeutics may have on the heart, including blood pressure, clots forming, things like that. But the most important one that we wanted to monitor is the actual pumping ability of the heart. And I'll get to that in a little bit about how we measure how well the heart pumps to make sure that heart function doesn't go down and cause something called a cardiomyopathy, or CHF. These are terms you may have heard from cardiologists or other doctors. So a lot of different ways have been developed to define cardiotoxicity. So since 1983, when there was a new boom in trials to research new cancer therapeutics, and they wanted to see what the adverse effects are. Because in the 1970s, one of the biggest chemotherapies that was developed was doxorubicin, or adriamycin. This is commonly used for breast cancer and some lymphomas. And one of the biggest toxicities was cardiomyopathy, or decreased heart function from the adriamycin. And so when they're developing new drugs, they wanted to instill standards. And these standards have changed through the years, and now they're on the 5th version of these standards and how they define what a decreased heart function actually is and what the cutoff number is, which is a little bit debatable. And I'll get to that in just a second. So cardiomyopathy. What you need to know about this. Cardiomyopathy is an abnormal heart function, or decreased heart function. It's basically the heart is not able to pump an adequate amount of blood. The signs that you can look for as a patient or a patient's caregiver are things like shortness of breath. When you're walking around the grocery store, you notice now, I can't make it the whole way. I have to stop a couple minutes and stand or sit down before I have to get going again because I'm getting too short of breath to continue through. Other signs include lower extremity swelling. Your legs start swelling. You notice that the socks on your feet, there's an imprint from where the elastic socks are on the feet. And the other most specific sign is when you lie flat in bed at night, you notice that you get very short of breath when you're lying flat. You feel like you can't breathe. You feel like you're drowning. And a lot of patients will start using multiple pillows to prop themselves up, or they'll sleep in a recliner because when they lie flat, that heart getting backed up with fluid goes to the lungs, and then that's what gives that sensation of not being able to breathe, or this drowning sensation when they lie flat. And that's a term that we call orthopnea, but I don't want to get lost in the lingo, the doctor lingo. So this is a nice little movie of one of the most common ways nowadays that we check heart function. It's called echocardiogram, or a heart ultrasound. This is the same type of technology they do to look at the babies in the tummies when they do ultrasounds before birth, but we do it on the heart. And so here's an example of a normal functioning heart. You can see there at the top how it squeezes nicely, and we do very specific measurements to see how well the heart is squeezing. And the reason that this has kind of become the imaging of choice for monitoring heart function is because, one, it's ultrasound. There's no radiation, the extra radiation that you have to get from it. It's very portable. We can take an ultrasound machine almost anywhere. When patients are in the hospital, we can take it right to the bedside. You don't have to travel down, or you don't have to be in an enclosed CT scanner or MRI machine where some patients have claustrophobia and can't tolerate those types of things. And also, in relation to the other imaging things like CT and MRI, it's relatively a lot cheaper to do the ultrasound. So all these things are good benefits of doing it. A very portable, fast, no radiation, and non-invasive. It's just a little bit of cold gel that you get on the chest, and they get different views. You don't have to go inside your body. You don't have to put needles in your arm or anything like that. So all these are benefits to ultrasound, and this technology has improved vastly over the last 20, 30 years. The images we're getting now are so much better than they were even a decade ago. And this is part of my research interest, is to find newer ways and newer technologies within ultrasound that we can earlier find problems in the heart muscle so we can tackle them earlier or get you on medications to help stop this from progressing or even reverse it. And so that's my goal with ultrasounds. So this is the way we measure it. We measure what's called the ejection fraction. So we take the heart when it fills all the way up, and we measure how big it is, and we measure how big it is after it squeezes all the blood out. And so that by that fraction, we determine how much blood is pumped out with each beat. And that's the main way that we measure how much, how the heart function is squeezing. That being said, I don't want you to get caught up on numbers. If you go to your cardiologist or you go to your oncologist and they say your EF, your ejection fraction, was 58%, and the next time you get the test, they say it's 56. You say, oh no, I dropped 2%. That's not clinically significant, all right? So what we call a real drop has to be over 10%. So and don't get caught up too much in these small variations. These are all variability in how one reader for the ultrasound will measure compared to the next reader. So a little change like that is not significant. And you really have to interpret these numbers by talking to your doctor. You know, so we don't want you to worry or unnecessarily worry about small little changes in the actual number. So let's talk about doxorubicin a little bit. The brand name for this is adriamycin. This was initially studied in the 70s, has been one of the mainstays of treatment, as I mentioned, for breast cancer and lymphomas and sarcomas also. And so if you get your records, as I'm sure many of you do, you'll notice various regimens written by the oncologist, and they have AC, TAC, ABVD. These are all different regimens that include doxorubicin in them. And one of the big points with doxorubicin is that the possible effect on the heart, or possibility of it to decrease the heart function, is all dependent on the cumulative dose. So how much you've received over a lifetime. And as the dose gets higher, the risk of the heart function going down gets higher. When this was initially studied back in the 70s, people got various doses, all the way from 50 milligrams to all the way to over 5,000. Now, that being said, even though the more you receive, the better chance of the heart function decreasing, that one patient that got 5,000 in the 70s never developed any heart dysfunction. So this is why it can get a little confusing, because some patients can receive as much of this medication as you can possibly give them, and they'll never develop heart function. And other people, for reasons we don't know why, may only receive one dose or very small doses and still develop some heart dysfunction. Although this is pretty rare, but it's still a possibility. And so the next med that's almost very commonly used is called trastuzumab, or Herceptin is the brand name. This is used for breast cancer, and when they do the biopsy for your breast cancer, they do these special tests on it to see what type of receptors or hormones are positive within the cancer itself. And this is used for the ones that have HER2 positive. So if you look at the records and you see the breast cancer showed HER2 positive, this is a common regimen they'll usually give. So this was initially being studied in the 1990s. It got approved in 1998. And one of the unfortunate things with initial trials on different therapies is that usually these trials are done in a small number of patients. The initial trial is less than 100 patients. And so with how rare it is to develop heart problems, with only 100 patients, you might not get any patients that develop heart problems with that, and you may not expect to have heart problems. And it's not until it's later introduced into trials where they have a lot more patients that we find some heart dysfunction. And that was one of the things that happened with trastuzumab. So when it was initially studied, they thought, you know, this is not going to have any effect on the heart. And any effects on the heart, these patients had already received the other med, doxorubicin, in the past. And they said it was probably due to the doxorubicin and not the trastuzumab. But later it was found out that actually the trastuzumab was causing some problems. Now, one of the big differences is between trastuzumab and doxorubicin, the previous med, is that trastuzumab is largely reversible. a heart dysfunction, whereas doxorubicin has been classically described as irreversible, but up to 20% of people can actually reverse the heart dysfunction from that if we get you on the right medications. And so those are two big differences that we'll talk about. So if you look at this table, I don't want to get too specific with anything, but to highlight some of the points I've made, doxorubicin on the left, classically described as irreversible. This really isn't true. There's 1 in 5 patients will have a reversibility from the heart dysfunction with it. And trastuzumab is largely reversible. So if you have your heart function decrease with trastuzumab, we'll often try to reinitiate after the heart function recovers. Try a reinitiation of trastuzumab because these meds really work. And the chance that it will decrease again may be there, but it's so low that you may have more benefit from treating the cancer than the heart. And we'll put you on meds to help prevent the heart function from decreasing. Now, how often do we do the ultrasounds? This is the other big difference between doxorubicin and trastuzumab. So before you receive any of these, we'll often do a baseline ultrasound. So we'll see what the heart function is before. Vast majority of patients have very normal heart function before receiving any. Now, just because you may not have normal heart function before, some patients who have already had some heart disease, may have had blockages in their heart arteries, cause the heart function to be decreased, that does not exclude you absolutely from receiving doxorubicin or trastuzumab, but it puts you at maybe some increased risk. And so that's why it's helpful to see a cardiologist to make sure you're on good medications that can possibly prevent the further decrease in heart function, or to give you that risk and say, let's talk with the oncologist and see if your risk is too high because you already have some decreased heart function. Maybe there's an alternate chemotherapy or a new chemotherapy they're developing that has almost as good efficacy or maybe even the same that we can consider an alternate regimen. But this is really a shared decision making between you, your oncologist, and the cardiologist. It's a team effort because nothing's 100%. And everything has some risk associated with it, but we have to determine what's the other part of it. There may be a risk of the heart developing some dysfunction, but what if we can't treat your cancer effectively? That also has risk too, real risk that usually it's worth it to treat the cancer and accept that there may be some risk of the heart dysfunction, but we'll monitor it closely and take care of it if it does happen. And so that's what the most common scenario that we run into. Oh, also on this slide, you'll notice for the doxorubicin, there's different ways they've developed. Because this was classically described as irreversible, different ways they've developed to help prevent the cardiotoxicity or the decreased heart function from developing. One of the ways is they infuse it slower. So sometimes you have to be admitted to the hospital and get a slow infusion of the doxorubicin to help limit the effects on the heart. Another way is they have different ways the pharmacy mixes the medication or the way it's prepared, and there's something called a liposomal formulation, which has less cardiotoxicity or decreased heart function associated with it. And then there's another med, which is rarely used, so I'm a little hesitant to mention it, but it's called dexrazoxane. And I've seen it's more often used in the pediatric population, in kids who need who have a higher risk of the whole lifespan of developing some toxicity because they're getting these chemotherapies at such a young age. But it can sometimes be used in adults also, and this can help prevent heart dysfunction from happening. The hesitancy in using it is that there's some concern that it may decrease the effectiveness of the doxorubicin itself. And so they don't want to decrease the effectiveness of it treating the cancer itself. And so that's why it's kind of less used in adults. So this is just a little graph, and I don't want to get lost in the weeds here, but it's showing that as the dose increases down there on the bottom, the probability of developing the CHF term, as you get to much higher doses, the probability goes a lot higher that you'll develop a heart dysfunction. So if you look at the doses on the bottom, you see that 400 is where it kind of really starts going up a lot more. Well, the most common max dose used in breast cancer nowadays is 240, so way below that 400. And so looking at breast cancer specifically, at 240 milligrams, the risk of any heart dysfunction is probably about 3%, maybe even less. And so that's good news. And like I said before, most of what we treat here at MD Anderson as a cardiologist is not the toxicity from the cancer therapeutic you're receiving, but rather other heart conditions that you've had before and not related to your cancer or your cancer therapeutics at all. Now, that being said also, sarcomas use a lot, the oncologists have to use higher doses of the doxorubicin. So you may get up in that 400, 450 range where there's about a 5% risk of heart function decreasing. And we go over those risks with you in the clinic and tell you those signs I mentioned earlier of the shortness of breath, the leg swelling, the getting short of breath when you lie flat, to watch out for those. If any of those develop, I give all my patients my card to my personal office and say, call my office, we'll get you in for an ultrasound immediately, we'll evaluate you. And so it's just being vigilant and knowing the signs of a decreased heart function and catching it early. It allows us to treat it better. And these are two graphs also just showing that if you have a history of heart disease, this graph on the right, then there's a higher risk at lower doses of the doxorubicin. And the graph on the left shows that as you get older, the risk is higher. And so for the cancer guidelines they say the elevated risk is above 60, which this graph kind of shows here, above 60 years old. And then if there's any heart disease before, if you've had stents, if you've had heart attacks in the past, that risk is a little bit higher. But still, that does not preclude you or deny you from receiving these therapies. It's just that we're a little more vigilant in monitoring and making sure that you don't develop these heart problems from it. So this is kind of going over what we just mentioned. The higher doses of anthracycline is another word for doxorubicin. It's that class of chemotherapy. So doxorubicin above the 250 is what they call elevated risk, but it's still above 250 or about 3% risk. And then let's talk about radiation. So I mentioned the RT here, that's radiotherapy. A lot of patients receive radiation after they have received the chemotherapy like doxorubicin or trastuzumab. Radiation can progress blockages in the heart. And usually they only progress if the radiation is to the chest. And this is a point that I make very clear to my patients, that if you need radiation therapy, I highly recommend you come to an MD Anderson or MD Anderson facility, because the radiation oncologists here are phenomenal in blocking the heart from receiving as much radiation as possible. Whereas you may not receive that same amount of blocking or precision radiation if you go outside of MD Anderson, just because they're so specialized here, and they really treat cancer well. And the radiation oncologists are so smart. I mean, they're way above my head, and all the physics they know and how they align these radiation beams to miss the heart. Some of you that need radiation may have a pacemaker. And if you have a pacemaker, you know the most common site is right above the left chest here. So if there's cancer right behind that pacemaker and you need radiation, sometimes we have to move that pacemaker to the other side. But we have a cardiologist here and a pacemaker specialist. They call them EP physicians or electrophysiologists, and they do that. We do that here. But it's rare that we have to do that, but it's only if the cancer is right behind there and the radiation oncologist says, I can't get to it, I can't give the radiation to it without going through the pacemaker, and so sometimes they have to move it over. And that's a pretty rare scenario, but it does happen, and that's why I mention it. So the other things, as we saw on the last slide, if you have multiple cardiovascular risk factors or cardiovascular disease risk factors, like you had a long history of smoking, which also puts you at increased risk for cancer. So a lot of the risk factors for smoking, for heart disease, are the same risk factors for cancer. So a healthy lifestyle of quitting smoking, if you are smoking, or not starting up smoking definitely in your life, are good ways to help prevent your cancer and help prevent your heart disease from developing. Now, high blood pressure, diabetes, high cholesterol, obesity. The obesity itself can also put you at increased risk for cancer, and including heart disease. So share a lot of common risk factors that if we address these early, we can prevent further cancer from happening, and also prevent the heart blockages from happening. So this is the current clinical guidelines from the oncologist, and they recommend doing a baseline ultrasound of the heart before any potentially toxic chemotherapy or cancer therapeutic. And the reason I mention this is that a lot of you may have been approached about clinical trials at MD Anderson. If you've been through other cancer therapeutics and things aren't working, and they say, well, we have this clinical trial, we can try something. We don't know the potential for cardiotoxicity in a lot of these newer meds. And some of these newer meds, we're realizing they may have some, but we don't know what the actual chance of that happening is. So we're pretty vigilant here at MD Anderson about doing baseline heart studies before you start these therapies. And then at the sign of any symptoms, we'll repeat an ultrasound or we'll do surveillance and monitoring to make sure these newer medications aren't causing any heart dysfunction. And it's not all about the imaging. We have to talk to you. So we like seeing you in clinic, talking to you, teasing out what's going on. You know, there may be some things you say, well, I'm fatigued, I'm just so tired, and you think to yourself, yeah, that's expected. It's from the cancer. I have cancer. I'm being treated for cancer. My blood counts are low. Of course I'm fatigued, and you blow it off and say it's nothing. But by coming to a cardiologist at MD Anderson, maybe I'll tease out that maybe this is something else. And most of the time it's not. Most of the time it is the cancer or the blood count's low. But by asking these specific questions, a cardiologist can help determine, hey, there's something else going on here, and we can treat it, and you'll feel better, and you won't have to feel this miserable going through your cancer therapy. And so I think that's why it's important not to minimize your symptoms when you're at home. You know, don't just attribute everything to the cancer. Some things aren't the cancer itself. It could be something else. We already mentioned the different ways we look at heart function. So ultrasound is the most common, ultrasound of the heart, because of it's so portable and it's no radiation. But sometimes we don't get good images with the ultrasound just because of where the heart's located in the chest, or you may have had surgery before and there's some scar tissue and we can't see with the ultrasound waves. So there's different ways we can look at the heart function. One of those is a cardiac MRI. Also, we can do, they used to do these earlier in the 80s and 90s, and they're called MUGA scans, and it's a nuclear scan. So there's a little bit of radiation associated with that, but a very minimal amount of radiation. And then those are different ways we can evaluate the heart function if the ultrasound is not doing it. We also check different levels or markers in the blood that tell us the stretching of the heart muscle or leaking of enzymes from the heart muscle that can alert us to ways that we need to work up further if there's any heart problems at all. So, after you have completed your cancer therapy and your cancer has gone away, you're in remission 4 years, 5 months out, the way we monitor you is we see you periodically. We can start spreading out how often we see you. 1 year, 2 years, 3 years, 5 years, depending on how well you're doing. And depending on what treatments you received, we can do surveillance with ultrasounds to make sure that heart function is staying normal. Now, at the same time, we highly recommend a healthy lifestyle with exercise. When I say exercise, I mean daily walking. So if you look at the American Heart Association, their recommendations, and the American College of Cardiology, they recommend 30 to 45 minutes a day of walking. We're not asking you to go run a marathon or go weightlifting in the gym. It's just walking, enjoying, walking is so therapeutic, not just for making you feel better, but it relaxes you. You get to calm your mind. I know it's hard to find those 30 minutes a day or 45 minutes a day. Definitely, I have busy schedules. I have 3 young kids. It's very difficult, but if you make it a habit and fit it into your schedule, it's so helpful for you. And the other thing is controlling those cardiovascular risk factors, like the high blood pressure, the diabetes, losing some weight if there's some obesity. And so controlling these things all help prevent the future possibility of cardiac side effects from the medicines that you received in the past. So now let's go into some of the newer therapies that have developed. And I don't see a clock. I don't know where I am on time. Am I doing okay? Okay, good. So some of the newer therapies, these are called tyrosine kinase inhibitors, or TKIs. And the toxicities from these are a little bit different than the ones that we had talked about with doxorubicin and trastuzumab. So the main ones that we see are something we see on an EKG called QT prolongation. And this probably doesn't mean a whole lot to you, but the reason it's important is because it puts you at increased risk for arrhythmias. And so with any new therapy, they're very vigilant in monitoring EKGs. So if you enter a clinical trial, before you get each dose of that new med, you'll usually receive 3 EKGs back to back to back. And they'll average what this QTC number is to make sure you're not at increased risk for developing arrhythmia. And they'll make sure while you're receiving, if it's an infusion, while you're receiving it, they'll usually monitor your heart with the little EKG leads and make sure that this QTC isn't prolonging while you're getting the med. The reason they're so vigilant on this is not because this is a problem only the cancer medications. This is a problem that they see with a lot of nausea medications, things like Zofran or the generic name is ondansetron or Phenergan. These things increase the QTC, and then we've also seen it with a lot of psychiatric meds that can cause the QTC. So there's a lot of problems with those medications. So now any medication that gets introduced, including the cancer therapeutics, we have to monitor this very carefully. And there's only two of the TKIs or the tyrosine kinase inhibitors that have this effect, and so we have to be a little vigilant in monitoring the EKG. And these are the ones probably haven't heard of them, but dasatinib and nilotinib. Now, the other thing with TKIs is that all these therapies are more targeted. Now, while they're more targeted than the old chemotherapies that they used to use in the 70s and 80s, they are still not so specific. They only affect that one little thing on that one little cell. So there's some cross-reactivity, meaning that they affect other cells also or other targets. And it's these off-targets that cause the side effects we're seeing. And so one of them is blood pressure. So the main thing we see with TKIs is high blood pressure. And as the dose increases, there's more of these off-target effects and affecting other cells and affecting the blood pressure more. And so my main goal as a cardiologist here is to make sure you get your cancer therapy. So I'm very aggressive in getting people's blood pressure medications up titrated and getting them to a good dose where the blood pressure is controlled so they can continue receiving their TKI. I will usually give you written down instructions to start this medication, and every 3 days you're checking your blood pressure every day, but every 3 days increasing it to the next level. And then I follow up weekly. A lot of my patients send me an email with their blood pressure log for the week, and this is what doses they're sending. And I can do that over the phone. So you don't have time to come in and see me every week to get these meds to the right levels that you need them at so that you can continue your medications. And a lot of these things can be done over the phone or through the email. So I'm proactive in doing it where you don't have to come in and see me, because otherwise you're wasting your time. A lot of you come in from far away, you're driving 3 hours and dealing with Houston traffic, so we can do things over the phone and by email. Now, the other problem with TKIs is some of them have caused clotting, and one of the meds is called ponatinib. And so the symptoms to watch out for, whether you have a clot. So if you have a clot in the vein in one of your legs, you'll have one-sided swelling in that leg. And so if one of your legs all of a sudden swells up, you should get evaluated. Usually they do an ultrasound on the veins in the leg to make sure that vein isn't blocked, and all of a sudden now the swelling is happening on that one side. If it's swelling in both legs, it's probably not a clot unless you have clots in both, which is very rare. It wouldn't happen. And so the clot in that one leg can cause that. Now, if you have a clot in the artery, the symptoms are very different. The symptoms of a clot in the artery are usually very painful. So if you have a clot that goes in an artery to the hand, you'll notice a lot of pain in the fingers, and maybe some weakness in the muscle, because it's like putting a tourniquet on the arm. Because if a clot goes in the artery, the blood can't get to the hand, and then there's a lot of pain. You see some discoloration, looks a little bluish. Those things to watch out for. Now, these things are super rare, so I don't want to scare you with, maybe a clot in the leg or a clot in the arm, but those are all signs to watch out for with those medications. Now, the last new therapy that I wanted to mention are something called immune checkpoint inhibitors. So we briefly mentioned this at the beginning of the talk, how these new therapies are using your own immune system to fight cancer, which is really amazing if you think about it. And so there's a lot of different ones that have been developed. You're probably, I'm seeing at home a lot of commercials for these medicines. You're probably seeing them too. One of them is nivolumab, or Opdivo is the brand name. There's pembrolizumab or Keytruda. And so there's a lot of new meds coming out. And 33% of the trials at MD Anderson, last I checked, are on these new immune checkpoint inhibitors. Now, why is this important? Is because they stimulate your immune system. And the point is to stimulate that immune system to fight the cancer. Just like your immune system wouldn't fight an infection. Now, the problem is when the immune system gets stimulated, sometimes the immune system misinterprets an organ in your body for the cancer. And so it causes inflammation or fighting an organ. Now, I get worried when it fights the heart. It can be very dangerous. And we call that myocarditis, or inflammation of the heart muscle. One of the most common side effects you'll see from these immune checkpoint inhibitors is rashes. As your immune system gets activated and flares up, you see dermatologic or skin rashes are very common. But the one I'm most concerned about is the myocarditis, or the inflammation in the heart muscle. And the way we often work that up now, we've just instilled a new protocol where we're hyper vigilant. If we see any sign at all in your labs or an extra heartbeat, we do an ultrasound, and we also do a heart MRI, a cardiac MRI, to look for this myocarditis. An MRI is a very good test for looking at myocarditis. Now, if the MRI comes back for inflammation being positive in the heart, we may even proceed to do a biopsy of the heart. This is an invasive procedure. It's pretty rare that we have to do it, but it is a procedure that we do and we offer here at MD Anderson if we have to do that. And we go through a vein. Now, the good news is that there are no pain receptors in the heart, so you do not feel the biopsy when we do it in the heart. All you feel is when we go in through the vein on the outside, but we give you nice sedation and lidocaine to numb the area for that. But that's pretty rare that we'd have to do anything like that. Right now, what we've seen is probably less than 1% of inflammation in the heart with these new therapies, but we're making sure that it's not higher than that. Just as I had mentioned in the past, they realized later with the trastuzumab that the number was actually from the trastuzumab was a lot higher, and we want to make sure we're not missing that same thing with these new therapies. We don't want history to repeat itself, and so that's why we're vigilant about that. This is just a little cartoon showing how the immune system attacks the cancer and how the cancer tries to evade the immune system with these new therapies. They block that evading mechanism of the cancer. So really trying to outsmart the cancer is the key. So in conclusion, probably finishing a little bit early, but I hope I didn't get too in depth with anything, and I don't want to lose anyone on some of these things. I don't want to get too detailed. But monitoring cardiac function with the heart ultrasound is very common practice. We do a lot of ultrasounds here. We do 70 to 90 ultrasounds a day, and our echo lab is very busy, but we get you in and out pretty quickly. It takes about 30 minutes. It's a 30-minute exam over there in the echo lab. Now, echo is one of my passions and my interest, and so it's an evolving technology that's forever is always improving, and I'm looking at different newer ways that the ultrasound, not just from looking at the way the wall is squeezed, but looking at the actual muscle fibers within the heart on the ultrasound, and how we can predict or find earlier heart dysfunction by looking at the echo and not having to go in and do a biopsy of the heart. And it's key for you as patients and caregivers to know the signs of a decreased heart function. And that's why I repeated those several times. The shortness of breath, the swelling in the legs, the shortness of breath when you lie flat, especially at night, having to sleep in a recliner. Those are all signs that you have decreased heart function. And recognition of those signs early so that we can tackle it and figure out what it is and figure out if we need to get you on treatment are very important. And then, like I said, none of this precludes you from receiving your cancer therapy. It's a joint discussion of what are the risks, what are the alternatives to therapy for your cancer, and how can we help prevent this cancer therapeutic from causing any heart dysfunction. And the long-term monitoring we do in the survivorship clinics, I see many patients who have survived their cancer, even patients who survived their lymphoma at young 9 years old, 8 years old, and now they're in their early 30s, and they want to make sure, hey, this hasn't had any effect on my heart. And we do periodic echoes every 5 years if they're doing great at that point, and making sure that they're not having any issues, and making sure they're on a healthy lifestyle, healthy diet, not picking up smoking, make sure their blood pressure is not going high, and we can get on top of that early. And so that's basically the conclusion of my talk, and I think now we can open it up to questions.
Dr. Palaskis stepped on my toes. He did part of my job. Thank you, Dr. Palaskis, for sharing your expertise. We will now open up the floor for questions. I would like to remind you that we're recording, so if you have a question, there's a little device that's sitting there that you have to press so that we can hear you, as well as the cameras can pick up your question. Does anyone have any questions?
The echoes are transesophageal echoes that you have to take.
So the question was what percentage of the echoes are transesophageal, and so what a transesophageal echo, just so everyone knows, is that's where we have to take an ultrasound probe and we sedate you and we numb up your throat and we have you swallow the probe so we can get a close-up view of the heart. This is very rare. We do about 2 to 4 transesophageal a day, and it's usually for looking for infection in the heart. And this is 2 to 4 echoes a day that are transesophageal, and we do 70 to 90 echoes a day of the transthoracic or on the chest. And so the most common reason we look for is the infection, and the other one is we're looking for a specific clot in the heart for patients that have atrial fibrillation. It's an arrhythmia that puts you at increased risk for having a clot, and it's in an area that we can only see with the transesophageal, and that's why we don't do the transthoracic. So whatever 2 to 4 out of 70 to 90, whatever that percentage is, it's probably around 5% maybe. I'm guessing, I don't know, my math may be fuzzy, but it's around there.
Okay, next one. Can you push the button? Right here.
Yeah.
You see the bottom portion of it?
I can repeat the question if you need me to.
Just hold it.
Oh, can you hear me now?
Yes.
Yeah. Thank you for the talk. I'm like an MI patient. I'm going through like a lot of medical technologies, but I'm going through like this is my 4th year of kidney cancer. I had a lung nodules and I had a craniotomy in my brain, but I'm still alive, and MD Anderson is doing great jobs. So a lot of times, like the cardiotoxicity, as you mentioned, it's kind of not in the radar since I'm on a heart attack 10 years back. I came alive. I'm very asymptomatic, even including cancer. So what, as a patient, what I know I'm going to get an appointment with you, but what, as a patient, what are all the things we need to do to kind of, one is watching the symptoms, but a lot of us are sometimes asymptomatic, or we think, oh, I walked too much, my knee got swollen, rather than my heart, or like even a blood clot. As a patient, what do you recommend? I know like the ultrasounds, the cardiac MRI, all of them are there, but with overwhelming information and already with like I'm on an immuno combination trial right now, it's kind of hard for us to look at each part separately, but for the heart point of view, what do you recommend as a patient to look at few steps, like few simple steps?
Exactly. So some simple things to do for if you had a history of a heart attack is, like you mentioned, watching the symptoms. For looking for that chest pain or chest pressure, that aching or elephant on the chest, or the classic symptoms, but going back to what your symptoms were when you had your heart attack. And that's your index chest pain is what we call it. So recognizing that, hey, this is similar to my last heart attack. I want to make sure this isn't my heart attack again. And if that's the case, I believe that more than any, we can describe classic findings all day, but everyone's different and everyone presents differently. And if you've had a heart attack before, you know what it feels like to you. And if it feels the same to you, it makes me much more vigilant to make sure that that's not happening again. Now, with simple things for you to do, did they ever send you to cardiac rehab after your heart attack?
Yeah, I was in a cardiac rehab for 12 weeks. Also, even after the brain, I've been on a lot of therapies, and I've been on the rehab.
Perfect. Well, that's good to hear, because unfortunately, cardiac rehab is highly underutilized in the nation. It's probably one of the best things you can do, and basically, cardiac rehab is just physical therapy. It's exercise, and that's exactly what it is. I would recommend the walking. I know your knee was swelling up, and it may be difficult. If there's another non-impact thing, like a stationary bike or something like that you could do for maybe 30 minutes a day in low intensity, not Lance Armstrong or anything like that. Just it's something gentle. You can watch TV. You're breathing normally while you're doing the stationary bike. Something to get that daily activity up, and then diet. It's all about diet. So a diet that is low in these refined sugars, simple carbohydrates, so things that, things we know, of course, like cakes that have candy bars, all these things have a lot of sugar. But things you may not know about are things like, rice. It's a simple carbohydrate, white rice, white bread, white pasta. Those things have a lot of simple carbohydrates, and we shouldn't overload ourselves on those things. You know, everything in moderation. We can take those every now and then, but it shouldn't be a daily, every meal I'm eating heaps of pasta. You know, and those things have a lot of carbohydrates that long term are not good for the heart vessels. And so looking at a diet that has a lot of fresh vegetables and some fruits mixed in there too, that is been more heart healthy. So diet, daily exercise, and then making sure you're on the right medication regimen for someone who's had a heart attack. A baby aspirin 81 milligrams a day. A good medium to high potency cholesterol medication. The most common of these are statins, like atorvastatin or Lipitor, Crestor, things like these.
On the statin drugs, they say with immunotherapies. So I was
Exactly.
on and off, but again.
So, and I've ran into this. So some of the immunotherapies can affect the liver, and so can the statin drugs. And so it becomes a trouble for the oncologist is the toxicity from my immunotherapy, or is it from the cholesterol medication on for your heart? If you've had a heart attack, or a recent heart attack especially, I'm a little more pushy in putting you on that cholesterol medication to make sure that you don't have another heart attack. And then we can monitor liver function, and we can determine whether it's from the statin or the immunotherapy at that time, rather than say, well, because we're not going to determine what the toxicity was, you may be at increased risk for a heart attack. Sometimes I'm not willing to accept that. But a lot of that depends on the specifics of your case, where your heart attack was, what artery it was in, how long ago it was, what your other vessels look like. So those are all things I look at to see what your specific risk is, and not just as a general, anyone who's had a heart attack, because everyone's a little bit different in that respect.
Thank you so much.
No, of course, thank you. And I'd love to see you if you want to come to the clinic. We can discuss.
Yes, I am a biochemist,
Uh-huh.
retired from MD Anderson, and I have
Mm-hmm.
Parkinson has created with the high technology the cancer and the heart and brain relationship. Both organs are 6% of the body weight, and the circulation is 20%.
Mm-hmm.
There is a interesting thing. The Israel development, they are working with Intel in relation to the way of pushing the regeneration. The compound is one of those things that stimulate vascularization.
Mm-hmm.
Are you familiar with that? I am interested in relation to the electroencephalogram and electrocardiogram, which is, I think, both are important, and you can take, you can review the behavior. I actually don't know if they have the
So I don't know the specifics about the new therapies for regeneration, but definitely everything is interconnected in the body. When patients have certain diseases in the brain, you can see alterations in the electrocardiogram or the EKG, as he's mentioning. That's where we measure the electrical activity in the heart. And so definitely they are interconnected. Now, in terms of regeneration, I recently met with a company that is trying to develop or 3D print a heart that is developed from, they're not really stem cells, they're a different type of cell, but you think of it in almost a similar way. And they're trying to 3D print a heart that's actually bioprinted. So it's not a foreign material. It's your own cells they take from your blood, and they get them to regenerate back into a cell that can go into anything, and they're trying to 3D print a heart from that. Now that technology is probably 25, 30, maybe 50 years down the road, but it would be so beneficial in that you wouldn't have to get a transplant for somebody else. You can actually 3D print your own heart and put it in, so you have no rejection issues whatsoever. You don't have a foreign or foreign material like an artificial heart, a total artificial heart. You could actually put in your own cells, so your body recognizes it as your own heart, which is, just fascinating. But that's way down the road. I don't know the medicines that you're referring to with regeneration, but I'll definitely look into it. That sounds, I think that's the way a lot of medicine is going. Is this specialized your personal cells and how your personal cells regenerate and use them for yourself. And that more targeted, personalized medicine is the way everything is going, as opposed to these blanket therapies for everyone. Oh, right here first? Okay, we'll get to you. Thank you. So the question was whether baby aspirin is a necessity. You're probably referring to recent guidelines from the U.S. Preventative Task Force that had a new recommendation for everyone with certain risk factors and above a certain age to be on a baby aspirin to protect from heart disease or heart attack. And this is data that's collected from over the whole population. And I have trouble taking data that's just blanket for everyone and applying it to everyone like that. And we have to go through each case and see what your true risk factors are, what your cancer is, and what the potential treatments for your cancer, whether your blood counts are going to drop, if your clotting ability is going to drop, and whether the risk of taking that baby aspirin may actually end up outweighing the benefit. A lot of people joke that the baby aspirin and then a little bit of the cholesterol medicine, because so many people are on them nowadays, that they joke that we should put it in the drinking water because so many people are on it. And that's really what I'm opposed to, is that I'm more of a minimalist in my approach to how I treat you. I only give you things if I really think you need it. Now, that's not to say there are different styles out there. There's different ways to practice medicine. There's different ways to treat people. Some people are more aggressive in getting people on medications, but I hate taking meds, personally. I'm sure a lot of you hate taking meds. So unless you really have a good indication to be on it, I usually won't put you on it. Now, what are good indications to be on a baby aspirin? If you have known blockages anywhere in the arteries in the body, in the heart, in the neck vessels, the carotids, in the legs, that's one of the best indications to be on a baby aspirin to help prevent further development of blockages or heart attacks or blockages in the neck. They go to the brain. All these types of things are really good reasons to be on it, and that's one I can tell you, yes, you should definitely be on it for. Everything else is kind of, you have to weigh the risk-benefit, because nothing comes without a little bit of risk. I hope that answered. I don't know if that answered your question, but hopefully it helped. Thank you.
Yeah. So you talked about immunotherapy and some adverse effects.
Mm-hmm.
So what is the main cause of that inflammation? Considering that immunotherapy is supposed to be specialized, so I'm thinking in the case that it stimulates the immune system, is it that the stimulated immune system does not recognize the heart, or is there something else going on?
It's actually just the opposite. So it's wrongly recognizing the heart as something that it needs to attack and fight. And so what we're seeing, so a lot of these immune therapies, they activate what are called T cells. And these are cells that fight infection and they fight cancer. And so what we've seen in the biopsies we've done on people's hearts that have immunotherapy that develop myocarditis is they have certain types of T cells that have infiltrated into the heart muscle. And so when we look at the heart muscle under slides, under a microscope, we see the heart muscle is infiltrated floridly with these T cells. And so they're attacking the heart like they would an infection or a cancer. And so they're, for some reason, it's probably some genetic difference. And these patients on their heart cells, they have a receptor or something that's on the outside of the cell that looks very similar to what they're designed to attack on the cancer or in the infection. And then they think it's the cancer or the infection, so they're attacking it like it is. And it's just your normal organ, which they shouldn't be attacking. And so I've talked with people who do a lot of the initial trials on these immunotherapies, and their suspicion is that, and they're trying to collect data, is sequencing people's genomes to see if there's any particular gene differences, that this set of people who has this gene, they express this receptor on their heart or in their thyroid or in their brain, and they express that receptor there, so they shouldn't receive this immunotherapy because it's going to cause these cells to go against that organ. And still, that's way down the road too. That's probably 10, 15, 20 years down the road, hopefully sooner. But that's the suspicion of what's going on. Good, great question. Thank you.
I have a comment, and I really enjoyed this presentation.
Thank you.
I've been a patient here since 2009. And I'm a four-time survivor, thriver, and this is one of the best presentations. You presented it to really understand, I guess, because I'm also a patient and I just did my echo today. Nice. And when I was in the clinic, I said, they get you right in, right out. I wish each department was like that department itself, because it is just so awesome. It really is. And you talked about Herceptin. I'm on Herceptin and Perjeta, and every 3 months my doctor look at my heart, and I pray that I can continue on those two medicines, because I feel that I'm here because of those two medicines. I've been, this month, it'll be 3 years that I was diagnosed my third time, and the fourth time was as of August, in the brain, 2 times in the breast, 1 time in the lung. And I wished I would have known the shortness of the breath, and that still exists. The third time, I didn't know what was going on, shortness of breath, coughing, and I ended up with a blood clot. I ended up with cancer in the lung. But I'm very thankful for MD Anderson, just on top of things. So I really appreciate your presenation.
Thank you for your comments and sharing your story. You're truly a fighter, and I appreciate you sharing with us. And your compliments are too kind, really. In our department, we're always trying to improve the timeliness and getting people in and out. I hate when my patients have to wait, and we just implemented a new system, actually, I think it was yesterday or today, maybe, where we have a new paging system in our clinic. And so if the doctor is behind in the clinic, then they'll notify you that, and they'll send you a text to your phone when the doctor is ready. And so you can go get something to eat, you can go, go down the cafeteria. You don't have to sit there in the waiting room, So we've just implemented it. We'll see if it works. Hopefully it works well. So we're always trying to improve that, and it's we thank you for your patience. I always thank my patients for their patience, because I know it can be very. I hate waiting. I've been to the doctor. My youngest daughter, she has a heart condition, and so I hate waiting for the doctor. But I understand your frustrations in that. But thank you for your comments. Yes. And no one gets out of the Texas Medical Center without paying for parking. Even we have to pay for parking, so parking is expensive. Yes. Thank you.
So being a breast cancer survivor and my disease was on the left side, how did the radiation oncologist not get my heart involved?
So the question was whether with cancer being on the left side, how does a radiation oncologist block the radiation from hitting the heart? And truly, the physics of this are above my head. It's way smarter than the people who do that are way smarter than me. But they do these targeted radiation beams, and they map everything out. So using the imaging they probably did, like CT scans and things, they map out where everything is in relation. Where's your cancer in relation to your lung, in relation to your chest wall, in relation to your arm, in relation to your heart. And then they have different technology, which I really don't understand, and how they focus the beam just on that cancer. And so the goal is to definitely not have the beam go through the heart, because that's what will give the most radiation. And still there's some scatter radiation that can happen where it hits the cancer and then it can bounce off to hit the heart, and that's harder to prevent, but they do phenomenal things with doing that. And I wish I could give you a better answer for how they do that, but I don't know the specifics of it actually. But yeah, they're phenomenal here. I've never seen a better radiation oncology group. Thank you.
Any more questions?
Does the immune checkpoint therapy ever cause the symptoms of rheumatoid arthritis?
So the question was whether the immune checkpoint therapy ever causes symptoms of rheumatoid arthritis, and I don't know, but you're right in that rheumatoid arthritis is an immune disease where your body is incorrectly identifying your joints as a possible infection or something, and it's causing inflammation in the joints. So that's a very good possibility. I don't know 100% yes or no, but I would assume that there are some cases of a flare in the joints and inflammation in the joints from immune checkpoint therapy. I would not be surprised if there were.
Would having rheumatoid arthritis keep you from using immune checkpoint therapy?
I don't believe it precludes you, but I don't know exactly. I'd have to talk to the trial investigators and see if they excluded patients that had rheumatologic conditions like rheumatoid arthritis. I'm not sure if they did. I'd have to ask them. I don't think they did, but I'm not sure. It's a good question, though. And it's a very good thought. You clearly understand the physiology of it pretty well to be able to make that connection, which is good. Great. Any question?
I do. I apologize, I forgot.
Thank you for sharing your knowledge with us, Doctor. I came here about 2 years ago on a clinical study, 2 cancer drugs. I'm very comfortable with my treatment and the recommendation of the oncologist, ibrutinib and venetoclax. And those were supposed to work in tandem to get me in remission. In March 2017, I accomplished that. Only to come back in February of 2018, numbers low, platelets, primary RBCs, and then only to discover that I had experienced some chest pains at home in Shreveport, Louisiana. And then in the last 3 weeks, I found out I'm a candidate for triple bypass.
Oh, my goodness.
So I guess my comment is I'm more probably a problem to myself and my diet, maybe my exercise, than the actual drugs. Would be a correct assessment?
Yes, the medicines you were on, so ibrutinib specifically, is most commonly associated with the arrhythmia atrial fibrillation, actually. And I don't know if this is true, but it may have had some effect. Ibrutinib has some blood thinning abilities itself. And so that's why when people develop atrial fibrillation on ibrutinib, we don't give extra blood thinners. And so it actually helps inhibit some of the platelets, the ibrutinib, which is beneficial for the heart. And so the reason you may not have had chest pain until later is maybe you're having some blood thinning ability with the ibrutinib, and then after stopping it, then things may have popped up. But definitely we don't treat heart blockages unless people have symptoms. And so when you started developing those chest pain symptoms, and they worked it up and they found that you had the blockages. Have you already had the surgery, or?
Right now, I'm starting tomorrow, number 2 infusion treatment to build the counts back up, and oncologists and cardiologists recommend maybe 3 weeks to 4 weeks before I can be a good risk for surgery. Yes.
Yeah, that's one of the problems with the platelets going low with a lot of cancers is that it puts you at increased risk for bleeding, and that increased risk of bleeding would preclude you from some surgeries, like a bypass surgery. But I hope the counts improve, and so you can get those blockages fixed for sure. Thank you for your comments. Thank you.
Okay. Are those all the questions? Thank you, Dr. Pulaskis.
Thank you.
You see them closing and outside. Okay, I want to thank Dr. Pulaskis again for sharing his expertise. Thank you, the audience, for your insightful and excellent questions. We hope that you found this session informative and that you have a better understanding of MD Anderson's efforts to help address survivorship's needs. Please be sure to complete your program evaluation as we value your feedback and suggestions on this and future picnic sessions. You may turn them in to the staff person at the door. There she is. Thank you again and have a great day. Thank you, Dr. Pulaski. You're welcome.